Welcome everyone to Rehabilitation for Daily Life Function for Persons with FDMAS. We're here with FDMAS advocate Tiffany Meyer and our medical advisor, Dr. Scott Powell of the NIH. This is a continuation of our educational webinar series, and you can find all of the recordings from our past programs on our website. I'm Tova Burstein, Community Engagement Director with FDMAS Alliance, and I'm going to start us off with some quick housekeeping. We are recording today's program and we'll be sharing it afterwards for anyone to access and share freely. We've collected questions ahead of time via our registration form, but we'll also be watching for questions on the Facebook chat. At the closeout, we'd really appreciate if you complete our 3-minute post-webinar survey, which helps us show our impact and continue to support webinars like this one. And finally, this program is made possible by our donors, with special thanks to Ultragenics and to our Charlie's Angels monthly giving circle. We're committed to keeping this material free, and you can help by making a donation on our website today. And with that, I am delighted to introduce you to Tiffany Meyer. Tiffany is a 37-year-old with McCune-Albright syndrome, fibrous dysplasia, who has a Bachelor of Science and Master's of Science in Nutrition and Dietetics, currently working in St. Louis as a medical secretary for Washington University School of Medicine at St. Louis Children's Hospital for the Division of Newborn Medicine. She's a proud daughter, younger sister, and aunt to 3 nephews and a niece. She lives in South St. Louis with her husband, Mark, of 7 years, and cat, Millie. Tiffany, thank you so much for being here. Let me give you permission to share your screen.
Okay, great. Let me pull up my, let's see here. Yes. All right, let me pull this up from the, there we go. All right, thank you, Tova, for that wonderful introduction. As she said, my name is Tiffany Meyer. I'll actually be 38 next week, so that's pretty exciting. I've had MAS since the age of 10 months, so I wanted to start off by, you can see the picture there with me. I wanted to include that because I wanted to show what I look like. I do have short stature. I do walk with a crutch on my right arm. My lower legs are bowed and my hips are also bowed. So you can kind of see how that can impact mobility and my ability to exercise. So I'll kind of go through that in my presentation today. So I was initially diagnosed at 10 months with initial symptoms of precocious puberty, cafe au lait spots, and bone lesions, was all manifested by the age of 21 months old. I initiated care at Shriners Hospital in St. Louis, who works closely with Children's Hospital in St. Louis. And then I was also enrolled in the natural history study for McCune-Albright syndrome at NIH by the time I was 2.5. And I've been in that study ever since. I'm one of the longest running patients in that study. And I'm super grateful to Shriners and to NIH for the wonderful care I've received over the years. I wouldn't be the person I am today without the care that I received from them. Going through my early years, as children, grow, it can lead to a lot of bone fractures. I had an ovarian cyst removed when I was 2.5. I was diagnosed with rickets before the age of 5. They noted a leg length discrepancy. By age 6, I had fractures to my left and right femur, my right and left tibia, and I had both hips pinned. And by age 8, I had both femurs. I had rods inserted to strengthen the bone. And by age 9, I had rods inserted on both sides of my lower legs to strengthen those bones. I included this picture. It's me at Shriners Hospital. If you're not familiar with one of these casts, it's called the spica cast. It goes from the waist down. I had 4 of these in 5 years, so I'm definitely familiar with those. This is me as I got older. I was 8th grade going into high school. I had more orthopedic surgeries. Basically, I needed to have, from my hips down, straightened due to bowing. So I had rods inserted into my hips and then found that the bones were too soft. So they put me in an unexpected spica cast. And then after I got that off, my femur was weak. So I broke that and had to have a rod inserted there. And these devices on my lower legs in the picture are called tailor frames. They stick into your bone from the outside, and there's little dials with numbers that there's a strict schedule every day that you turn to a certain number to straighten the bone from the outside. I had those for 6 months. And then after those were taken off, I had rods inserted into both my lower legs to strengthen the bone there. And then a couple years later, as I was almost graduating high school, I had a foot surgery on my right side to correct a deformity. They took bone from one side and then put it on the other to make it more straight. So then I went to college and grad school, and then started working full time and got married. So various things have happened since then. I had my thyroid removed in 2005. I had overactive thyroid for years, and now I'm on thyroid replacement medicine. I had my gallbladder removed in 2013. I had a lower GI surgery in May of 21. The left picture shows me after ulnar nerve entrapment surgery. It's basically like carpal tunnel surgery, but it's a different nerve. They moved the ulnar nerve from one part of my elbow to a different part to release pressure. I was having weakness and numbness and tingling in my left hand. So to preserve the function that I already had, they released a nerve, and now I'm just working to build back to baseline. I also have high cortisol as a result of adrenal adenomas, so we're monitoring that. We're not exactly sure what the cortisol is doing in terms of fibrous dysplasia. It can lead to some bone changes, so we're just trying to figure out what that's doing, but monitoring it for now. I could eventually have to have the adrenal adenomas removed. Last fall, I developed swallowing issues where I would eat like a chunk of meat or something, and it would feel like it was going down my throat too soon. So there wasn't anything majorly wrong with my swallow, but I just do swallow exercises, and I did outpatient therapy for about 4 to 6 months to try to strengthen the muscles there. And most recently, I have a Band-Aid today on my face and the gauze here in the picture. In July, I developed random cheek swelling under the skin, and it became more red and bigger and swelling. So they admitted me for antibiotics in the hospital, and I had 2 surgeries. I went home on the antibiotics and a home IV, and then I developed reactions to those antibiotics. So it's still kind of an ongoing issue with some lingering infection, but I think that I'm finally on the mend with that. So throughout all this process, now that you kind of know my background, I wanted to explain how I have a big emphasis on exercise in my life. This is a picture of me when I was 10 in the 4th grade at the bike derby at school. I couldn't ride a traditional bike. Well, it was safer to ride more of an adult tricycle that you see in the picture because it's more stable. We got this in Chicago, custom made. And all the kids loved my bike at the rally, so it was really fun. But I rode that from that age until I was in high school and went to college. And then my legs started to bow on my lower leg, so it was harder for me to go through the rotation of the pedals. So unfortunately, I'm unable to ride a traditional bike or that bicycle at this time. But then I started focusing on swimming. Swimming is very low impact after surgeries. I want to go back and say that physical therapy is key in the hospital and outpatient after surgery to get back to baseline. And then when you do more of a home exercise regimen like the bike or the swimming, you can do therapy on your own. I've been swimming on a regular basis, not just summers, since the summer of 2006. So I'm very proud of that. And I'm very functional today because swimming is such a great exercise. My parents have a pool. They've had one for over 20 years. And I remember them picking me up and putting me in a family friend's pool where I couldn't move my legs hardly at all to where I can endurance swim and lap swim now. But there are other ways to exercise. I do walk short distances with my crutch. I'm not able to stand or walk too long of a distance. I do have lordosis, which is where the bottom part of my spine curves outward, so that can lead to lower back pain and impacts my ability to stand or walk long periods. In college, I would push my manual wheelchair around as a cart with all my books, and if I was tired, I could just sit down, so it was convenient. And then when I went to grad school, I had a manual wheelchair and an electric scooter, but I didn't want to exclusively use the scooter. So I use the manual wheelchair, and I would push myself around in that to get exercise. So now that I'm married and I work full time, I work from home 4 days a week and in the office 1 day a week. Before COVID, I was working every day, weekday in the office. So now I incorporate exercise in my prior to work routine. I do household chores, so I sweep and dust mop. I stand to do the dusting. I do cooking and cleanup, but I don't stand at the stove. I use a stool to help because I can't stand forever. And I included a picture here of my pedal cycler. You can use it as a hand exercise tool, but I use it as a bike, like almost a recumbent bike, to be able to still do the rotation of a bicycle. I do arm weights and floor exercises like leg lifts as well. I don't really feel that it's exercise, but it is. I do strength training with for speech therapy. I have like almost a reverse inhaler where you blow into it and it helps strengthen what's called your expiratory muscles. So I do that 3 times a week for maintenance. Since I've been a little run down with recent surgeries of my arm and being in the hospital for my cheek, I haven't been swimming as much as I'm used to. I swim every other week at the gym, and I want to get back to every week or more once I'm back to my normal. But I do a routine where I do 12 laps, which is a third of a mile, which takes about 20 minutes. And then I do water walking and kicks in the pool, which takes another 20 minutes. So total exercise would be about 40 to 45 minutes. And I also do arm and hand exercises after my ulnar surgery to help bring back my strength with that. These pictures I just included for fun. I call it Cattercise. My cat, Millie, we call her pet therapist. She likes to, quote unquote, help me exercise, mostly just sits in the middle of things. But she's on the left and the right there, but she's sitting there with my stress ball for my ulnar exercises and my other equipment that I use. And then on the right, she's basically just standing on me while I do my arm weights, but she thinks she's helping. So these next pictures are me swimming because like I said, it's a huge part of my life. One of my nephews is in the picture on the left. Max, he's 7 at this time. I think he was 5 at the time, but he jumped on my back as I was doing my laps. So I decided that he was going to be resistance and me walking in the water to do my water walking. So that was a fun memory for us. And then on the right, even if you're on vacation, if your hotel has a pool, you can just bring your suit, swim in there and get your laps in. And that's what I did while we were in Branson last year. So how I deal with pain and how that impacts my exercise. I have a relatively low pain level, so I'm lucky in that regard. I only take like a Tylenol and Aleve. I do take stronger stuff if I need it, but I'm very stubborn. I don't like to take that stronger medicine because it makes me feel tired and I just don't like it. And like I said, I'm lucky enough to not have a large pain level despite, my extensive involvement in most of the bones of my body with the McCune-Albright syndrome and fibrous dysplasia. There is a fine line between too much and too little activity. My husband and I just got back from Disney World. We were there for 2 weeks and he's a saint and pushing me around the whole time and literally walked 98 miles and pushing me around, and I stay in the chair for safety. So he is hurting from walking almost 100 miles and I'm hurting because I'm not walking and sitting. So it's definitely there's a balance. You just have to find your own personal one. My family and friends are amazing. I'm a pretty happy-go-lucky person in the most part too. So I just like to have fun with my friends and family, doing little things, finding the joy in little things like games on my tablet or movies or TV or a good meal. Just things like that keep me happy and help me distract me from any pain that I might have. I'm definitely super stubborn. You can ask my husband. He told me he was going to take my keys away one time when I said I was going to the gym when I had a broken rib. And I said, well, I'm going anyway. So, and I've literally jumped out of bed when I forgot my arm exercises or something for the day. So I'm definitely stubborn. So it helps to have that kind of personality to stay committed. And I do have a positive attitude. I'm not perfect. I do wear down at times and I can lash out. And but I for the most part, I have a positive attitude, and I love the person I am with McCune-Albright syndrome and fibrous dysplasia, because it makes me a stronger person dealing with adversity and more compassionate. And I've met a lot of amazing people because of it. So on that note, I wanted to say thank you to my parents. They're listening today. They've always been super supportive growing up. They've emphasized, I have, how to be an advocate for myself with medical issues. They've always involved me in my care, asking questions and not sugarcoating anything. I still talk to them about medical issues. So I really appreciate them. So thanks, Mom and Dad, for all that you've done for me and continue to do. The picture on the right is from my wedding. Mark and I have been married 7 years. He's amazing. I've known him for 20. We've been married for 7. And he, like I said, he literally pushes me 100 miles around on vacation. He's always there for the little things. We're going to get through it together. And he's always holding my hand, being there for me when I need him. And this is just in addition to all the other family and friends that I have who are very supportive in my life. Well, that concludes my talk at this time. I appreciate your attention. I wanted to introduce Dr. Paul. Let me stop screen sharing here if I can. Sorry, this is where. I don't know, I'll figure that out. But am I still screen sharing? Sorry.
Yeah, here, I can pull it back.
Yeah, thank you. Sorry, I'm not great with Zoom. Oh, great. Okay. And then, so I wanted to introduce Dr. Paul. Let me pull that up. Again, sorry, I'm not great with this. Here it is. Here it is. Okay, so Dr. Paul is, I've known him since I was 13, so he's more of a friend at this point, as well as an amazing doctor. So Dr. Paul, you're awesome. Thank you. Dr. Scott Paul is a diplomat of the American Board of Physical Medicine and Rehabilitation with subspecialty certification in pediatric rehabilitation medicine. He is the research coordinator for the medical staff section of the Rehabilitation Medicine Department and is the principal investigator of a protocol investigating the use of computerized three-dimensional surface imaging to study persons with scoliosis and other trunk deformities. In addition, he serves as an associate investigator in a number of NIH Institute and Center protocols, including research on polyostotic fibrous dysplasia. He has authored a number of abstracts, articles, and book chapters relating to childhood onset disabilities and has served as editor and editorial board leader on a number of medical research journals. Dr. Paul is also an adjunct assistant professor in the departments of biomedical engineering and physical medicine rehabilitation at the Johns Hopkins University School of Medicine, where he developed and directs a series of courses on rehabilitation engineering. So without further ado, here's Dr. Paul.
Thank you. Let's, first of all, can you guys see my screen?
Yes.
Yes.
And it should have a title with 3 apples. So hopefully that keeps the doctor away a little bit. And first of all, thank you to Tiffany for number 1, giving my lecture so I don't have to. 2, for the kind introduction. And I have to say, it's really nice to hear that I've done a bunch of things in the last couple of years. But I think the most important thing that I get to do is to try to interact with and help and advocate for people with various disabilities. And I've had a really fantastic experience working with my colleagues in the National Institute for Dental and Craniofacial Research, which is where the McCune-Albright protocols live, and most importantly, all the amazing patients and families who I've gotten to work with, our research partners, because that's what we consider you here at NIH. So now let's kind of talk about this and see if there's anything that Tiffany didn't already tell you about. And first of all, many of you may not know what a physiatrist is. So a couple of years back, we finally made it via Doonesbury to the public by being recognized in a series where he was writing about the wounded warriors coming back. And this is actually, the drawing there is actually a real physiatrist from Walter Reed named Jeff Gamble. And we're kind of the Rodney Dangerfield of specialties in a way, because we're misunderstood. People don't know how to say our name. As a physiatrist, as a physiatrist. I like physiatrist because physics is where it's at for us, and because then you don't think I'm a psychiatrist or a podiatrist. But we don't own an organ system. We focus on people who have issues with function as it relates to a medical condition, and I'll explain that to you in one of the slides coming up. But most importantly, anything I say is general, but you're an individual. So always consult your local medical and rehabilitation professionals before plunging into doing anything. Tiffany's a great example of that. She's always collaborated with us and with her team back in St. Louis so that she can optimize her function with minimizing risk. So that's what, remember, CYLP. Okay, now let's talk about stuff you already know. I'll tell you a secret. My superpower as is obviousness, and so I'm going to go into my obvious man mode and tell you stuff you already know. But it's a help to build the understanding of how to approach things, because if you think of it, there's sort of like a series of dominoes that fall, and what you're going to do in trying to improve function and trying to address rehab is to stand all those dominoes up. So you have to know what they are. So what does Rosby-Kuhl-Albright syndrome do to the musculoskeletal systems? Fibrous dysplasia causes problems with bone and joint alignment. That can go as far as causing significant deformities. The famous one is the hip, which instead of having, if you're seeing me, if this is where the head of the femur, the top of the ball of the ball and socket, instead of it looking kind of like this, it now looks like little Bo Peep's little stick, which is called the crook, the shepherd's crook. And that's the classic example of a bony deformity. You also can get curves in the spine, and you can have leg length discrepancies, which means, as Tiffany said, one leg gets longer than the other, and that doesn't just affect the legs, it affects other things. And most famously, you can have fractures. So these conditions result in impairments in function. You could have pain, weakness, loss of mobility in the joints, which we call loss of range of motion, deconditioning, which is generally having problems with being able to having the energy to maintain everyday life function. And so what does that affect? Not surprisingly, it affects walking and getting around. It affects the things you need to do on an everyday basis, dressing, bathing, toileting, eating. It affects the higher level aspects of daily life function. Those both you have to do, like homework, homemaking, and work at school, and those things you want to do, like interacting with other humans, especially including on an intimate basis with your partner. So here's a way to think about it. I mentioned before, think about it as sort of dominoes, but you can also think about it as you have a pebble that falls into a still pond, and that's fibrous dysplasia. It ripples out and it causes impairments, which are the things like pain and weakness and things like that. And then that ripples out and can cause limitations in everyday life function, which we often call disabilities. And then, we can't forget this, then disability and handicap are not the same thing. Handicap is what society does to you because you have functional limitations. So we have handicaps when we have cities without curb cuts and you're in a wheelchair, or buildings without ramp access and you have trouble climbing the stairs. So how do we help in rehab? How can a rehab program help all these things? Well, let's go over first basic principles that we apply in rehab. The first thing we try to do is prevent or minimize those impairments, pain, weakness, loss of mobility. If you could prevent them from happening or minimize them, then your function will likely be better. When you can't, then we have to figure out ways as a rehab team to help you compensate for disabilities. So sometimes, sometimes we say, even if something is broken, you can't fix it. If you can't fix it, how can you compensate for it? And how do we do this? There's no blood test for rehab effectiveness. So all we can do is say, as a team, with you as our partner, the person, you and your family and your lay team with our professional team, set goals that we think are reasonable, realistic, safe, and relevant. And we set short-term goals, and then based on the achievement of the short-term goals, we work towards long-term goals. An example of realistic and relevant is a famous joke about a guy who goes to the orthopedist to have his cast taken off after he was casted for breaking his arm, and he goes, "Doc, now that you're taking the cast off, can I play violin?" He says, "Sure, your arm's as good as new. Go ahead, play violin." He says, "That's great, because I could never play very well before." How do we do these things? And it's hard when I don't hear the reaction. I'm sure there was some noises in the background, but I'm a dad and a granddad, so I don't tell just dad jokes, I tell granddad jokes. So what do? We use physical approaches. That's why it's physical medicine rehab. That's why it's physiatrist. That's why we like physics is where it's at. We use physical modalities. We sometimes use medications as well, but we use physical approaches. That means heat and cold and light and electricity and weights, using all of Newtonian physics, which is what you're doing when you're doing physical therapy a lot. That's how we try to do those minimizing of impairments and compensating for disabilities. So what does that mean for someone with a bone condition? That means our goals are to keep you straight, supple, in other words, that your joints move, strong, and safe. All right, so how do we affect the impairments? So the most important thing is this medication. I just told you that we don't use meds, but we do. This is one that Tiffany stressed, and you will, those of you who understand chemistry, dihydro means two hydrogens, monoxide means one oxygen atom, otherwise known as H2O. So water really can be your friend, because what is water? It's buoyant, it's shock absorbing, it's pain relieving, especially if it's warm, and you have to, it's a force against the body, so you're doing strengthening when you do it. And if you can't swim, Tiffany swims and she swims very well, but she also mentioned that she does upright exercises in the water, and that can also help. And there's a little asterisk down there that says if you have trouble or you feel uncomfortable supporting yourself upright in the pool, there are different types of vests and flotation suits that can help you. Warm is better. Warm is better because it helps loosen the rubber band tissues in your body, and it feels better. So what can this do? It can help you with improving mobility, strength, endurance, range of motion, and pain. What if you don't have a pool? Well, if you don't have a pool at home and there's not a nearby gym, Tiffany mentioned something when she was on vacation in Branson, Missouri, that she used the hotel pool. If you're in a little tiny town, but it has a hotel or motel, especially one that has an indoor pool, you'll find that that pool is hardly ever used by people who come and stop overnight in that hotel. So if there's no YMCA, there's no community center, and you want to use a pool, you can approach the owner and manager of that hotel that's where the pool's never being used and say, I need this for a medical reason. We can generate some good publicity for your hotel in the local newspapers. And would you let me use your pool? If that doesn't work, then depending on your stature, A hot tub, which is less expensive than a full-size pool, can sometimes help. And if you're a little kid, even a standard tub might help and work. So that is a great way to do strength and flexibility without putting stress and risk of fractures. What do we do about this leg length discrepancy? Well, the first thing that you should know is it in and of itself doesn't really matter. It's how it affects your symmetry and your balance when you're standing and walking. So that is, you don't fix something based on an X-ray, you fix it based on a person's function. X-rays can help give you a clue, but they're not what you're treating. You're not treating a picture, you're treating a person. And there's other factors you have to consider. That the joints may have loose ligaments. So if you adjust the difference in a leg length, then you may change something else. Everything's connected. It's a the series of dominoes. It all has to be considered before you do things. So how do we deal with that? We can modify your shoes. Again, don't do this. Just don't go to the store and say, oh, I'll get it. I'm going to order some shoe lifts and that's how much you're going to put in. That'll be great. No, you really need a local team to work with you on that. If there's no physiatrist in your area, ask your orthopedist if you have one, collaborating with your physical therapist, and that's how you should make these decisions. Try not to do it on your own. So what do we try to do with this lift? We are trying to level the pelvis so that your body is not walking and putting extra stress on the spine because one leg moves this much and the other leg only moves this much. That also puts asymmetric stress on the legs themselves. So if all we have is a leg length discrepancy, we can offer a lift. How much can you put inside a shoe? For a good shoe, you can get up to 3/8 of an inch in there. Any more than that, and your heel's going to start coming out of the shoe, and it's going to almost be walking on a high heel, which is not good for body walking mechanics, and also is not good for the shoe being supportive and helping you. If you have a tendency to flat feet, we can also add shoe inserts that call orthoses, and the insert can have the lift on it. If you need more than 3/8 of a lift, it needs to be put on the outside of the shoe. Even though I said outsole there's actually, if this is the part of the shoe where your foot is, so there's a midsole and then this very bottom part, which is, and so if you think about a sneaker, it's the little spongy marshmallow part is where you would cut in and add the length. Slapping it right on the bottom is not aesthetic and it really doesn't help. Because you're making that shoe now stiff, the toes may not bend when you're walking anymore. So that's why you might need to add what we call a rocker. We see many times we'll see people have a lift. There's no rocker. So now your toes can't bend, and that movement that you do right before your foot's going to step off is no longer in its normal mechanics, and that's going to put more stress on the leg, including the knees. So it's not like you can just go to a shoe man and say, hey, make this for me. You have to understand the biomechanics, and that's why you need your local professional team. If you want to find the person who makes these, it's usually made by somebody called a ped orthist as opposed to an orthotist. We're fortunate right now at NIH that we have somebody who is actually a certified orthotist prosthetist who has a long history, and he wanted to kind of work not full-time and work in an interesting place. So he is actually all three. But orthotists usually make bigger braces that go up your legs, and they don't usually want to focus on this. So a ped orthist is probably the better choice. And that's a web link for where you can find them. There's a search from the American Board of Certification in Orthotics and Prosthetics that can help you find people in your area. So what we call malalignment, the joints and the bones aren't lining up. Why is that happening in fibrous dysplasia? Well, it could be the fibrous dysplasia itself, but it can also be loose ligaments, laxity in the joints. Fibrous dysplasia is something that me as a rehab professional, rehab professionals, we can't directly influence, but we can help you with laxity. Again, CYLP, but there's things you can do. If the rubber bands are loose, you can strengthen the motors attached to the rubber bands. That's muscle strength. And sometimes you may want to use some type of a brace to support the overstretchy rubber bands that hold your joints together. We think it may be possible. We don't know because, again, remember, it's a relatively rare disease and it's hard to make definitive statements. But we think that doing these techniques to control laxity might slow the malalignment even due to the fibrous dysplasia, because if the forces are going through the bone in a more normal biomechanic way, then it may not be stressing the parts of the bone that are challenged by the FD, and those forces are put on asymmetrically and then cause things like bowing, for example. So what about the bony deformities? True bony deformities, as opposed to like, joints being out of alignment. Well, we mostly think that it's due to the FD, changing the geometry of the bone, the geometry and the physiology of the bone. And then that results in the bone not being able to take the stress of pounding into the ground, which is weight bearing. And that we think helps cause bone that was not deformed to deform over time, to develop things like the shepherd crook or bowing in the tibias or in the femora. So what can we do about that? There are things that might be able to reduce, if you reduce the stress on the bone, the asymmetry on the weight bearing, maybe that can help. Again, CYLP, but there's what we call assisted devices that help take some of the force off the legs when you're getting around on 2 feet. Types of braces, correcting the leg length discrepancy with the things we talked about before. Correcting it surgically would require a lot of strong discussion. Number one, about at what age to do it. Number two, are the types of devices which have come a little bit away from the tailor frames that Tiffany was showing you in a picture, where you're essentially having an erector set on the outside of your legs that has a screw that's tightened every once in a while, to now rods with essentially motors in the middle of them that you can put them inside and wave a wand essentially, and through the fact that magnetism and electricity are related, can turn that motor on and do the stretching from inside the bone. Either way though, remember, we're dealing with bone that's not normally happy bone. So you have to really think before you do a surgery. Surgeries are not without their own challenges and complications. And so I would probably recommend that surgery not done unless you've tried all the non-surgical things. And even if you're going to do the surgery, that your local rehab professionals and your endocrinologist, if you have one, and your orthopedist should have a good discussion amongst themselves, and then the team preferably with you, so you understand what you're getting into and you make your best informed decision. Strengthening exercises, again, because strengthening exercises, if you strengthen the right muscles so that they keep the bones in alignment, that may be able to help as well. What about losses in joint mobility? Well, why is there a loss in joint mobility? Why is it not going through the normal range of motion? Is it due to the actual bone itself? Or is it due to the rubber bands and the muscles, the ligaments and the tendons, and even the connective tissues of the muscle? Have they gotten tight? So unfortunately, the bony restrictions in general, once they become significant enough, the things we talked about on the last slide, it's probably past their time. So we can't do much for that. That's when we move from minimizing impairment to adapting to the disability and compensating for it with rehab devices and such. But if it's soft tissue, the rubber band tissues, ligaments, tendons, and muscles, you can stretch them. And if you stretch them, you might be able to get better alignment back. What about fractures? Where do we come in? Fractures is an orthopedic thing. I didn't want to be an orthopedist because I didn't want to have to get up in the middle of the night at my current age and do surgeries. I wanted to sleep through the night if the rest of my body lets me. So remember, with fractures, always consult your local rehab professional, and in this case, orthopedic professional. There are things we think that we can do to prevent fractures. If the body's balanced and symmetric, then it's less likely that when it's challenged by stepping on a pebble or getting off of a curb onto grass or something like that, that it'll be balanced enough so there won't be that excessive force that then causes a fracture. And if the muscles are stronger, if a movement, if it was carried out the rest of the way, could cause a break, the muscles may be able to catch you before you fall, so to speak. And then we want to reduce the fracture impact. Once you've had a fracture, if you can't move and you can't do this, all these different things can happen. So this is where you need to talk to the orthopedist and say, I don't want to get deconditioned. I don't want everything else to get worse because I had this one fracture. What can we do? And how can I move? And how much weight can I put on this limb so we can keep on going? And what are you going to do to prevent the other areas becoming tight and contracted? If you are restricted in how much you can move around, you're at that much more risk of those areas becoming tight, and contracted means that they can't even be stretched anymore. So that's where, even once you've had a fracture, there's a role for rehab. In addition, obviously, don't let the other areas get weak. So since we mentioned weak, let's talk about muscle weakness. What causes muscle weakness in a bone condition? Well, it could be due to any of the challenges we've already talked about. And that's why to start, you have to say, what is likely cause and what are the complicating factors? Is this because you couldn't move because you had pain, because you had a fracture, now it got weak? Or is there something else going on? You have to do strength exercises carefully. That's why it's good to have a team, have a therapist, make sure that you're doing it right before you go off and do it on your own. With the physician basically saying, hey, this is what's safe, but they can be done. They just have to do it safely. Water is probably the safest place. And what about how we do strength training? You want to do something where you're sustaining the muscle, holding the muscle tight, preferably against some kind of force, if you're able to provide resistance of some point. You can do resistance without moving the muscle at all, which is like if you imagine pushing your hand against the wall's not moving, you're not moving. But because this is individualized based on where you have fibrous dysplasia, what your history and background with exercise is, you really have to know your limits and have a team who knows your limits. It doesn't try to push you beyond what's realistically your limits, so that you don't go 2 steps back for the 1 step forward of exercise. Now, what do we mean by deconditioning? In general, that means decreased endurance, whereas before you could walk with your crutch for a mile before you'd be exhausted. Now you can only walk a half a mile. How does this happen? There's a vicious cycle. Once you can't move, once you have pain, you don't move. Once you don't move, you get weaker. Once you get weaker, it impairs your endurance. Once you've had weakness and you have less endurance, you're now in pain and you're going to go to your general doctor, and then you might get treatment for the pain that then makes you less active for a period of time, and it's going to go around. It's because all those different reasons we talked about. How do we fix this? We gradually increase the intensity and the amount of time that you do things that are aerobic. Aerobic is walking. Aerobic is cycling. Aerobic is scooting across the floor if that's all you can do. Aerobic is having a job which keeps you on your feet. Any of these things. What does it mean to be aerobic exercise? Your heartbeat goes up and stays up for a while, and that's good for general health. It's, like I said, and obviously it's good for heart health and lung health. And whether you have McCune Albright or don't, we got to keep those lungs bringing in the air, and we need the heart to keep it pumping. Now, water may be the best way, obviously, to go swimming, to do water aerobics. And what else can we do? We can do walking, do long distance wheeling if you're a wheelchair if you can. You can do cycling like Tiffany used to. You could, all you can do is scoot around from one room to the other in your house. And it's possible that Tiffany's now doing some speech exercises, and she's doing the thing to sort of strengthen her lungs. It's possible that wind instruments may be able to do the same thing. So you may never have played the violin before, but if you played the trumpet or the trombone and you want to get back to it, or the clarinet or the bassoon, then it may be able to help with developing strength in the breathing muscles. Again, I will say it every time, consult your local rehab professional. Do not rely on knowing the answers and causing then a bigger problem that you started with. Pain. Pain is unfortunately a part of having McCune Albright syndrome with polyostatic fibrous dysplasia. It's where it's there. So what can you do? First, understand where the pain came from and focus the treatment towards that. Temperature modalities are great for pain. Cold will numb the area and reduce swelling. Heat will relax muscles and soft tissues and feels good. TENS is a little electrode thing that kind of buzzes, and it's possible that having that may essentially tell the brain that there's a buzzing signal coming through and not let the pain signal come through. Certain massage techniques, just general relaxation techniques, which is because the primary organ of brain is the pain is the brain. So you can train your brain. And acupuncture can sometimes work. And if there's specific areas of tenderness, local injections can work. So now let's go on to from trying to minimize impairments to compensating for disabilities. I apologize that we kind of knew between Tiffany and I were probably going to run over 1 o'clock. We're both willing to stay here to answer questions. And I will give Tova my slides so she can share them with people if they're interested. This is the kind of pirate I like. He stands up for people with disabilities because he has some himself. So what do we do for walking? Different types of braces can support and control malalignment and make it easier to walk. Assistive devices, which is the canes and the walkers, and I'll show you pictures of all sorts of different ones, may be able to relieve some of the weight that a leg can't tolerate. So you can still go on 2 legs and maybe 1 cane, or 2 legs and the 4 points of a walker. Some people don't like walkers if they're young. I would say that a walker is like glasses. If you don't wear glasses, you're going to bump into things. If you don't have a walker and you can't get around, that can create a problem. But just like people will trick out their glasses and get fashionable ones, there's no reason you can't pimp your walker and declare it stylish. So can this help? Well, we did a study that suggested that working on strength and range of motion improves the efficiency of walking, and especially focusing on the hip and correcting leg length discrepancy may be able to keep you walking for longer. What do we mean by assistive devices? The classic is a single point cane. If you need more of a base of support, you can have a cane with 4 points on the bottom of it. You can have something even wider, which is sort of like a half walker. You can have like a half walker with wheels. You can use arm axillary or armpit crutches. You can use sort of the crutches that Franklin Roosevelt famously used, which are called forearm crutches. If you have problems with your arms, you may be able to use a cane by supporting your arm with a platform at the top of it. Those are also used on walkers. You can have a walker with or without wheels, with or without a platform, with or without 4 wheels and a seat. And though I'm not a big fan of these, sometimes for a short period of time, these one-leg walkers can be helpful. My concern in fibrous dysplasia is twofold. One, you could risk getting that knee that's sitting on the knee, kneeling part of the walker tight by staying in that flex position all the time. And two, you've now moved the force up to the knee and through the hip. And you really have to think about, is that going to be safe given the position of your fibrous dysplasia? So you want to be able to have enough energy to get through your day. So there's an approach, and an occupational therapists are the experts in going through the details of this. We call it energy conservation and work simplification. It's sort of institutionalized way to remember that easy does it. Don't blow your whole wad of energy on getting dressed when you want to do other things during the day. That might mean sit rather than stand. Keeping the things you need close by so you're not constantly getting up, walking somewhere, and going back. And thinking about the steps you're doing of an activity before you do it, so you can be strategic about how you're going to do it. If it's a cooking task, you might want to get all of the ingredients and the cutting board and the bowls before they're filled with stuff in one place. And then you might sit at a bar stool type stool, so you are at the right height for your counters. In general, just like in rehab, physics is where it's at for us. Make physics your friend. Use physics to make things easier. Slide when you can instead of lift. Use proper body mechanics. That's why you need a rehab professional, and put the work at the right height. And use adaptive equipment, and we'll talk about what that means in a minute. One example of adaptive equipment is a wheelchair, but it's really a mobility device. Now the question is manual versus power. And Tiffany has made some very good points about that. What is manual? Lighter, easier to move from place to place with you or without you in it. And it gives you its exercise. Between going full power and manual is something called power assist wheels. The wheels have motors, they fit on a manual chair. So if you can't push by yourself all the way, you now have electric wheels that can help you push. So you still get some aerobics, but you can use your wheelchair in a functional way. Then there's power. The problem is the problem is the solution. It doesn't rely on your strength. So if you have no strength, you can still get around. But if you have strength, you might lose strength by relying on it. The nice thing is you can have accessories that recline the back if you need that, lower yourself closer to the ground, raise yourself up to a good height. They even have stand-up ones. And they can interface with things called environmental controls that are how you can turn things on in your house, like the lights and the window shades and things like that. Now for the everyday activities, we have as many apps as the App Store, except they're physical apps. Here's some examples for bathroom safety. If you have trouble reaching to wash parts of your body, a sponge and a stick. Sit when you're doing your bathing, and there's different ways you can sit, which can be safer. The most dangerous place in any house is the bathroom if you're sober. If you're not sober, it's the stairs. That comes from Wait, Don't Tell Me, that reliable NPR show with facts. So you have different types of bath seats, including the one I'm showing you now, which allows you to sit down outside the bath and then slide yourself in. And this one, which lowers you up and down so you get down in the water. And this one, which is a full-size supportive seat and then slides in. Or maybe you just need help getting in and out, and so you have the clamp-on grab bar. Or this is an example of, the whole setup with different types of grab bars and the seat in your bathroom, and what height the various different devices, bathroom fixtures are. Just so I make this clear, we talk about grab bars. This is not what we mean by a bar in the shower. That just combined the two things that make life dangerous: drinking and the slippery bathrooms. Don't do that. What about toileting? It can be hard to get up and down from a toilet seat. So sometimes you can just put this on top of the seat, or you can have this as a toilet seat next to your bed, AKA a bedside commode, if you can't walk that far. Sometimes you can just put a little thing on top of the toilet if that's all you need to make it higher. Sometimes you get a toilet that has the height built in and even the arms. Sometimes your upper limbs are such that you can't reach the places you need to do hygiene to. So there are actually toilet wiping devices like the two I've shown here, so you can still do that independently. What about dressing? Lots of apps for that. Those are button hookers. Imagine what people use sometimes, a threaded needle, but you're using it to pull a button through the buttonhole. Pulls, so you can pull up on zippers easier. The general dressing stick, so you can pull and adjust different parts of your body to get clothes on. A sock putter-oner, okay, sock aid. A long-handled shoehorn. Laces that look like regular laces, but they're elastic, so you can tie them once. And the handy-dandy reacher. What about grooming? So sometimes you may have trouble getting toothpaste out of the tube, but if you love your toothpaste and you don't want to go to a liquid toothpaste, you can have something like that to help squeeze it out of the tube and hold it still, so you can put the toothbrush under it and get the toothpaste on the toothbrush. You may have trouble gripping the toothbrush. There's adaptive handles. You may have trouble reaching your head to brush your hair. Adaptive brushes. You may not be able to hold the hairdryer. Adaptive hairdryer mount. For eating, you may need built-up handles on your silverware. These are built-in ones. Sometimes you can also get something called tubular foam, which looks like the foam that they put around as insulation around different pipes, but very small, and that you can sometimes slide right onto your own flatware. A cup with extra grips. Different ways to open jars. Things to hold things still so you can cut them with one hand. Make it easier to open bottles and caps. Easier to open jars, another way. What about the house itself? Well, how can you make that more accessible? Door handles that are, there are door handles that are made like levers. There's door openers that you can add to an old-fashioned round doorknob. Reachers, like we already showed. If you need to move something from one room to another and you can't carry it, if you're on our side of the pond, we would call it a cart, like you can sometimes see in a restaurant. If you're on the other side of the Atlantic Ocean, they would call that a trolley. If you have stairs and you can't get up on stair lifts, or something you could consider if you don't want to consider changing your home. Appliances that have side swinging doors instead of pull down doors. Dishwashers that are sort of in drawers rather than with a big fall forward door that makes it hard for you to get to in a wheelchair. And then what can you do to modify your home? You can do ramps, widen doorways, lower the cabinets, and put pull-out shelves, lower the counters too, and have pull-out shelves, which are easier to pull things in and out of. What about at work? So every telephone headsets are ubiquitous now. I have what's now considered an old school one. And that way you don't have to hold the telephone when you're having a long conversation. Adaptive writing implements, just like we have adaptive eating implements, adaptive scissors, letter openers, how you set up your workstation. You can ask an occupational therapist to help you with that so that you're in a good body mechanics position. If you have trouble typing, there's voice recognition software. It's everywhere now. It's Alexa. And remember, at work, you have rights. The Americans with Disabilities Act says that your workplace has to afford you reasonable accommodations. What about for fun and fitness? There's adaptive equipment for needle crafts, for card games, for gardening tools and supports. And there are adaptive sports leagues and instruction. So you can still do exercise even with adaptation. And that's it. Unfortunately, it's 1 o'clock, so we could say this comic is pretty accurate in that there's maybe only time for yes or no questions, but I think that we can stick around and answer things. We can answer more than that. I thank you for your time. I thank you to all the patients and families who I've learned from and grown from. I thank the FD MAS Alliance for allowing me to make a contribution. And I thank all my colleagues at the NIH, the coolest place to work, where you get to really be a doctor instead of being like this guy, where you can only answer yes and no questions and you have to see a patient every 10 minutes. And I thank you for taking the time and putting up with my dad jokes.
Thank you both so much for sharing your experiences. As I said, we have questions that people sent in ahead of time. And then we also have a couple questions that are coming in. I will check back on the Facebook chat to see if there are other questions. So yeah, we'll get started. And definitely more than yes, no questions are welcome, or yes, no answers are welcomed. You talked a lot about the different ways to stay active. We did have a question that spoke specifically to geriatric patients, so patients as they're aging, and the mobility issues that they encounter. Do you have specific tips for that?
I'll take it since I'm older than Tiffany. And what I will say, as a person who will be 64 in June, I just look so young, that's all. 64, I heard Dr. Francis Collins told Dr. Tony Fauci on his retirement that 81 is the new 61. So that means I'm only, if we do the same math, that means I'm just in my 40s. So I will tell you what, Fauci, God bless him, he's a real gym rat. Before COVID, he was at the NIH gym all the time. What I will say is that when we get to our more uncertain ages, we have to think of ourselves as classic cars. If you think of a classic car, what distinguishes a classic car from a junker? A classic car is lovingly maintained by the person who is very proud of that car. And what that means is you can't abuse that car like you used to, and you have to be better about oil changes and better about replacing parts. I'm not saying we should replace parts, but what that means is that you have to be at least as dedicated as Tiffany is to exercise when you get older. If you haven't exercised, then you really, really, really need to have a local rehab professional team to identify, are there specific areas of challenges of flexibility, specific areas of weakness. And don't assume because you have pain in one area that that's the area of weakness. And I'll just briefly give you the example. I stopped going to the gym during COVID for obvious reasons. And my wife and I have been walking anywhere between 4 and 6.5 miles in the morning before the sun comes out, which allowed us to see the lunar eclipse yesterday. And I started having knee pain. And I realized, and I wasn't able to do things that I normally could do. And I said, all right, you're a rehab doctor, you're not your rehab doc. And I went to a guy who I knew was trained by one of my friends at Rehab Institute Chicago, who specialized in sports rehab. He did a very good comprehensive exam. He said, your knees are fine, your butt's got weak. So I did gluteal exercise. I went to a physical therapist. I followed her instructions. I did the exercises as I should have. And I still do those exercises the strength exercises every other day and the stretching exercises every day. And I'm not somebody who has a specific disability. I'm what they call a crab, currently regarded as able-bodied. So all the more so, or a fortiori, as people who like to throw some Latin around would say, all the more so if you have impairments, you have to be that careful about, one, starting slowly if you haven't, listening to your body as you're doing it, collaborating with your team, and you can't slack off even when you're on vacation.
Which I feel like, Tiffany, you really touched on with your swimming on vacation.
Yeah.
Along those lines, one thing that struck me while you were speaking, Dr. Paul, is that I can fall into the habit of thinking of rehab as something that you do post-op to recover from an injury, but you really talked about it in terms of preventative care, and how it can go a long way to sort of to prevent those certain pains and disabilities from developing. I'm wondering how then can somebody who isn't currently seeing anybody for that, how can I access that kind of care?
So the first thing to do is, if you have physicians you're already working with, say, I listened to this McCune Albright, this FDMAS Alliance lecture, and they said that there's a doctor who specializes in rehab who can help me put together a good team of therapists and others and work with me so that I have a good exercise program. Do you know anybody like that? And then you have to do, so President Reagan said a quote, and I won't say whether I was a big fan of his or not, but he said something about working with the Russians, which was called trust but verify. So if your doctor gives you some names, if you go to the American Academy of Physical Medicine and Rehabilitation website and do find a PM&R physician, and you see some names there, it's so easy to Google stalk people these days. See what they do, what they specialize in, if they seem like they're the best choice. If you have friends who also have fibrous dysplasia, who are in the general metropolitan area where you are, ask them, and then make your best choice, and then go to that doctor with a clear understanding of what you want to get out of them, and make it clear to them, this is why you're here, this is what you're asking for. And if they give you short shrift, then you say, well, see you later. If they say, yeah, I get it, and I want to help you, but my office only booked me for half an hour or for 15 minutes, say, okay, doc, then let's get started today, and let's talk to your office about fitting me in next week to finish the evaluation, because I have complicated needs. And the other thing you can do to help them is get them all your records in advance. You have access to all your records now. They may or may not read it, but the more you give them in advance, the more they're prepared.
And actually, you touched on this a little bit, but beyond sort of your assessment of them and whether that clinician is somebody who's going to listen to you and work with you and really focus on your priorities, is there any special certification for a rehab doctor with expertise in FDMAS or any special education in terms of that? So
as a specialty, we are a 4 years of training to be a general rehab, it's not so general, be a rehabilitation specialist. And you get training in rehabilitation of impairments and disabilities from various different medical conditions. There are people that do additional fellowships in sports medicine, in spine, in pediatrics, in spinal cord and brain injury. I actually have some specialty certification in pediatric rehab. Because because fibrous dysplasia is such a unique thing. Or the other thing that people specialize sometimes is in cancer rehab. And any of those specialists or generalists may actually be comfortable. There's no specific orthopedic rehab specialist. There's no certification for that. There are people who focus on that, but it's going to be hard. You need someone who is not just interested in doing procedures, which we have people like that who are like really good at doing local injections for people's spine disorders, something like that. You want somebody, the reason it's physical medicine and rehabilitation, it's physical medicine is our toolkit, rehab is the process. You need somebody who's going to be the team leader for that process, as well as, having a broad view of the toolkit and not just be like the old saying about the orthopedist that when you're a carpenter and your tool is a hammer, everything looks like a nail. So it unfortunately is not like, you may have to try a couple people. You may have to really do some due diligence. You may have to say, listen, this is where I'm at. The good news is you're not having to deal, some rehab physicians don't want to have to deal with people who have cognitive challenges. The good news is I'm sharp as a tack, but these are my impairments and these are my functional challenges as a result. Are you up to the challenge of working with me?
And then one more question along this line of reasoning. Is there special phrases or lingo that somebody with FD-MAS can use to help their clinician understand, other than saying that they have brittle bones or sensitive bones? Is there a way to communicate that differently?
You want to take that one first, Tiffany?
I'm not really sure. I mean, I just kind of say, here's what I have, because, if somebody doesn't really know about it, they can Google it. So I don't really, they're doctors, so I just I don't use any special terms. I don't know if that answers it accurately. I'm trying to think. But yeah, I don't say it in any special way. But a lot of times people say they know a lot about McCune. You're like, yeah, right, you don't. So about that. You're like, I don't believe you. But I find it important. Like, I have an excellent primary care physician who's willing to collaborate with anybody and everybody, including people like at NIH, that have more expertise in the field. So if you find somebody who's not egotistic and willing to go outside the box, then that's important too. I'm just really lucky to have really good people that I've found.
So I would say, in addition to that, I think Tiffany made a very important point. And that is that, physicians have an obligation to if they don't know something, look it up. And I can't tell you how much time I do that at NIH for all these rare different things that we get. And so I would say, if they say, well, I've never heard if they're honest enough to say, well, I've never seen anybody with your condition, where can I learn more about it? I would say that there are probably links on the FD-MAS Alliance page that would be.
I actually just want to mention that I put in the chat the treatment guidelines. That's not the same thing as lingo, lingo or phrases, but we often recommend that people print and bring the treatment guidelines to their appointments. And I did pin that in the chat as a resource for your doctors.
There's also a really wonderful website that's maintained by Hopkins. And I'm not saying that because I'm an alum, but the father of modern genetics, Victor McCusick, who's not with us anymore, but he lived a long life, made a lot of great contributions. He realized when he was studying genetics at a time when computers were entering data by punch cards, that genetics was going to be wide and broad and complicated. And so even though he wrote a book at that time called Online Mendelian Inheritance of Man, which was like the reference for all these different diseases, that was Mendelian. There's now something called Online Mendelian Inheritance of Man, omim.org. You can look up any genetic condition there. And McCune Albright has its own entry. And if the doc doesn't want to read all of the basic science stuff, it's got this cool cheat called Clinical Synopsis, where you can read all the different parts, all the different things that can be related to it. I'll put the link for MAS
Thank
in
you.
the chat.
I can share it.
That's a really easy way to have for the doc to learn a little bit. And the other thing is the Alliance has this medical advisory board I've heard of. And I think one of the things we're supposed to do is if docs reach out to the Alliance, they can talk to us alleged experts. So if you have a really committed physician, if you have a rehab physician who wants to somebody to talk to, they can talk to somebody like me.
Yeah, so my next question, I think every single one of these webinars, and certainly this one has reiterated that as well, is like getting your providers to work as a team. You mentioned having your endocrinologist, your orthopedist, all looking at things together. And as a patient seeking care, sometimes I find that really overwhelming. How do I encourage all these people who I see separately, whose offices I coordinate with separately, to put their heads together? I know they're busy. And Tiffany, it seems like you've been really successful doing that. Can you speak a little bit to that?
Well, I just found really good doctors is one thing who, like I said, aren't like, oh, I know everything and I'm not going to talk to anyone else. But just being my own advocate too, like I email NIH all the time and say, hey, what do you think of this? And do you mind talking to this person? And then I talk, I'm just articulate as a personality trait. So then I'm not afraid to be assertive and say, hey, can you do this? Or so I think that helps a lot. And if you're a child, if your parent is, articulate and willing to speak out and say, hey, can you do this for me or whatever? All you got to do is ask questions, and usually people are pretty compliant. And if they're pretty egotistic and they don't want to help, then you're like, yeah, bye. I've fired doctors before that I don't like, not often, but I'm just like, yeah, I don't really like you. So I'm thinking to myself, so I just gonna find somebody else. You don't need to put up with that. So,
Dr. Paul, do you have anything?
I would say, not every doctor is right for every patient. There's been times I don't connect to people. If you have a patient who doesn't like a doctor who talks too much and tells bad jokes, then and if some people want just like a really serious, like, here's the facts and I'll see you later, then I'm probably not the right doctor for that. But so it doesn't mean that you failed as a patient. It doesn't even mean that sometimes it may mean they're a bad doctor, but it doesn't always mean they're a bad doctor, just that they're not the doctor for you.
I've been writing down your excellent jokes, so I'll thank
wait,
you for that.
Don't tell me. That's pretty awesome.
Yeah. And then some of these questions are it is really going to be individual, but the decision to try to walk as much as possible. Tiffany, I'm not sure if you did as a child really try to walk rather than use your wheelchair as much as possible, but somebody's asking, what was that decision like, and how do you find that balance of walking, pushing yourself versus not pushing yourself? They're speaking about walking versus crutches, but that can be
well, sorry, I just remember when I was younger, we would go to a store or something, and I go to a parking lot, and I'd be like, okay, where's the car again? Give me something to strive for. So then it might be harder for me to do because it's a little bit past what I can do comfortably. But then I'm like, okay, well, it's pushing the boundaries to get to a next level somewhere. So even though I didn't mention it, as a kid, I did that too, trying to walk around. So yeah, I did do that. It's just finding, what's safe. Like I said, with Disney, you can't even get out of your chair because good luck with that. I did once and I face planted because I fell in the rain. But so it's just assessing the environment and the situation and seeing what's safe to do and what you can do physically, and then just trying to be as active with whatever the factors are that you
can. From a medical standpoint, do you have suggestions about pushing yourself versus, finding that balance of pushing yourself versus keeping yourself safe and protected?
It's each person's different. It's really listening to your body. And sometimes you may push yourself too much. Sometimes you may not push yourself enough. And you can talk to your team to give you certain guidelines. Like if someone has a very, very loose ligaments and they have a leg length discrepancy that you can't fully correct for some reason, or one, let's say you can correct the leg length, but the length of where the knees aren't lined up when you level up the legs, and they have a really big area of fibrous dysplasia in their femur, you're probably going to say, well, we don't want you doing jumping activities. We think that, if you have a lot of cranial FD, that even if you don't have a lot anywhere else, that maybe a competitive soccer with heading the ball would be a good idea for you. So for an individual, you can make recommendations to say that based on the pattern of your bones your bones physiology and anatomy, this would not be a place to go. But then it's more helping you listen. Like if you decided to walk 6 miles this morning and you wake up tomorrow and you can barely walk 6 feet, you overdid it. If you walk 3 miles and you have no pain at all, and you may want to do more. That's what we mean. That's what I mean by listening to your body.
Absolutely. I know I've got 4 more, I think, really important questions I'm hoping to get to. One of these, again, it's a personal question. I think this varies from person to person. But every time we have one of these webinars with somebody speaking from the community, we have parents coming and saying, I'm really worried about my child's ability to, I think also in adolescence, this is something that kids themselves have their questions about. I want to be able to live a full life. I want to be able to, do the thing, travel, go to Disney World, have a family, connect with others. And that can feel really overwhelming and scary, especially in the beginning years of having this diagnosis. Tiffany, can you speak to that a little bit?
I am lucky. I believe I do have a full life. I'm lucky to have found my husband who's super supportive. Tova, you and I were talking before we started. I'm just a bold person. Like I'll go up to anybody. So like I online dated before I met Mark. I'd already met Mark in college. So basically the background there is we met in college. I liked him. We both liked each other, didn't say anything. And then, we both went to our careers and stuff like that. And then we kept in touch as friends. And then eventually I was online dating and I'm like, wow, this guy's a jerk or whatever. There's a lot of jerks on there because people are shallow. Let's just say in general, for whatever reason, if you're, thick, thin, have a bone disease, not a bone disease, like people are just shallow in general. So I'm lucky to find somebody who can look past that and look in the inner, personality. So Mark is awesome. But eventually I said, hey, I've dated jerks. You're not a jerk. Why don't we go on a date? I liked you in college, FYI. And then he's like, oh, I don't want to ruin the friendship. And then we, you know, became more than friends. So long story short, I found a really great guy. I just been really lucky. But the takeaway from that is don't be afraid to put yourself out there, and don't, you know, have to get a hardened skin when it comes to, you know, people in general, because people can be mean, and, you know, they can suck at times. But just realize there are good people out there. If you just keep at it, you'll hopefully find that one person. And like I said, I don't have my own kids, but I have, you know, a cat, and I have 4 nieces, you know, 3 nephews and a niece. So I feel like, you know, my life is full in that regard with family. So it just depends on what you're wanting in life. So just put yourself out there as much as you can. But if you're a shy person, that's a little bit harder to do, I know, but I've never been shy. I don't know how to be shy. So sorry if I can't personally attest to that, but
I think
do what you can with your personality, I guess.
Yeah, I mean, I think one of the things that I love about having community voices on here is that everybody, you know, it's so personal, you know, not just the medical aspect of how this affects us, but also our personalities and our goals and our priorities. And there's so many different examples of that. And I'm always so grateful to people for sharing that. Thank you, Tiffany. I also want to say that there were some specific questions, you know, more specific about aging and about reproductive health. And we actually do have full webinars on those topics. So, you know, a complete session just like this. And I will also post the links to that so you can look more in depth at that
I want
later.
to just pop in really quick on the end of what you were saying. When I talked about rehab, I talked about sort of the classic rehab for MAS, which would be having the rehab physician, the physical therapist who's mobility, and occupational therapist who is more everyday life activities. And occasionally, like Tiffany mentioned, there's speech therapy. But we recognize in rehab that if you're trying to do rehab for a whole person, that there's an emotional and behavioral component to that. And I think that there are professionals, there are actually psychologists who specialize in rehab psychology. And I think that anyone, whether it be parents or a person with an impairment and disability at whatever age, if they're having trouble working out who they are because of the disability, then having a professional who's got skill and expertise in that area and work with them is really valuable.
Absolutely. Yeah. Actually, one observation I had when we do these registration surveys, we always ask, you know, how comfortable do you feel discussing whatever the topic is? So in this case, it was mobility and quality of life goals, your mobility and quality of life goals with your provider, with your family. And I was struck this time by our registration responses. It had a higher skew of people responding that they were uncomfortable. So people who aren't really, you know, I don't know how to talk to my doctor, my family about how much this has changed my life. And I wonder if that comes from a space of, you know, I'm not talking about like a specific medical issue, but more, you know, like, and Dr. Plumpton gave her presentation, you know, like, well, I have trouble brushing my hair. And, you know, oh, I don't know, I feel weird bringing that up to my doctor because that feels like, you know, it's not this big medical issue. And that's just, you know, one thing I'm zeroing in on, but that aspect of like the quality of life, my goals. And do you have suggestions for that? And you spoke a little bit to it, Dr. Paul, but about helping people really zero in on those mobility and quality of life priorities.
Part of our job as a rehab team is to ask you about that. Because that's our focus. And if we don't ask you and you don't tell us, and you're not telling us because, well, if we're not asking you, we're not doing our job. But if you feel uncomfortable or you minimize, and that's something you need to work through, if you're comfortable then with either peers who you can talk to, who can help give you suggestions, or professionals who that's their business, is understanding the emotional and behavioral impact of physical physical disabilities.
Absolutely. Tiffany, do you want to add anything?
I didn't have any additional to add. Sorry.
That's okay. I know. I mean, I think you said it in so many words, and that it sounds like your parents and really coached you to be your own advocate.
Yes, that's a huge thing. My parents are awesome. So
I will attest to that too.
It helps.
She knows my mom. She's my NIH buddy. He's seen my dad and Mark a few times too. So yep. My dad's like more quiet, and so is Mark. Mom and I are the chatters of the group in a good way. So
the balance.
Yeah.
Okay, so I do still have two quicker questions. The first is, how do I, let me find the question because it was worded well. Essentially, if you're interested in seeing, like, how do I get evaluated to see what kind of mobility devices might help me? How do I start that process of getting a wheelchair? Where do I begin?
I would say it's best not just to say I need a wheelchair and go to a wheelchair clinic, which they do exist, but it's better to first put together your local team and then work with your local team. And then for the specialized prescription of the wheelchair, you may, if you're in a big city, the rehab center there will have a wheelchair clinic, which means that there'll be a rehab physician, one or both of the therapists, OT and PT, and one or more vendors, so that you can kind of like talk about all the different aspects of it and make sure you get the right one. And also to know that even if you do it at a wheelchair clinic, where hopefully the chairs can be delivered to the clinic, not to your house, because you need to complete the loop. Any kind of device, it's like a prescription. If a doctor gives you a blood pressure medication, they don't say, here's the medicine, and now use the blood pressure machine that's right next to the pharmacy and tell the pharmacist what your blood pressure is and he'll adjust your dose. So same thing, you don't just go to you don't get a wheelchair prescription from a doctor and then go to a wheelchair guy, and the wheelchair guy or gal makes your wheelchair and just adjusts it. You just deal with them. Your rehab team should be involved with that, and you should know and discuss different options. So it's part of a rehab plan. It shouldn't be freestanding from that, if possible.
And you can start that process just through, like you said, your regular provider. You can say, like, I think I'd like to be assessed for this, and they can help connect you. They should help connect you.
If it's your rehab provider, yes. If it's your general internist, they may not understand, and they may just like send you to a wheelchair clinic if you're lucky, or they may just send you a wheelchair vendor, which is just about one step above just ordering it on television.
Okay. And then a very important question, it's maybe the question with the least soul, which I hate to end on, but important still nonetheless, insurance. How do I prompt insurance to cover this, if I'm being cut off after a certain number of visits or a certain number of days? What's my recourse?
Move, get another insurance? Actually, no, I'm joking, but you and your team have to be able to make a case to the insurance company that giving you this service will save them money in the end, because that's all they care about. If they don't get this wheelchair and then you fall down, they're going to have to pay for orthopedic surgery. That you're still making progress in this therapy, and you need the skilled therapist. The physician gives a letter, and that is even willing to talk to the medical director of the insurance company to say, well, this is your point. This is your choice, buddy. Give this person, another 2 months of therapy, and they'll be walking around independently on their own, or they won't, and then they'll develop other complications because they'll be deconditioned, blah, blah, blah. And even then, sometimes that won't be enough, unfortunately, because and I know this is being recorded. So this is being recorded, and I'm still an employee of the federal government. This is my own individual opinion. It does not reflect the opinion of the NIH, the NIH Clinical Center, the Department of Health and Human Services, or any branch of the federal government. But unfortunately, it appears that often insurance companies are penny wise and pound foolish.
Thank you for sharing that. And again, I'm struck by how important it is to be able to find providers who are willing to work with you and willing to take those extra steps, and you being an advocate to ask them to support you in that process.
And always bring your muscle with you. Tiffany does that, even though she's a great advocate for herself. She still brings her mom with her to NIH often, or Mark or somebody, because you may not hear, even, you may miss things.
Yeah, for sure.
Your advocate's going to hear it. And then you go back and say, hey, wait a second, they said what?
Absolutely.
Right, definitely, yeah. Definitely have a second person around to hear things. So,
if you can afford it and there's no other choice, there are actually professional healthcare advocates.
Sometimes a hospital will help provide a patient advocate too.
Patient advocates for the hospital are a little different than actually having, a paid muscle who might have a background as a nurse practitioner or as a physician or health or life care planner or something like that, who then will basically do that advocacy for you. It will not come cheap. So but they exist. So it's good to know they exist.
Definitely. We are now over a half an hour over. I think these are all really important questions, wonderful answers. At this point, I'm going to share my screen. I will put in the chat our links to those other webinars I mentioned. And I think we've reiterated the importance of a support network. There's a wonderful support network in the community of the FDMS community, and you can find and connect to those folks also on our website. I'd like to thank you so much, Dr. Paul, for your insight and expertise, to Tiffany for sharing your experience and being so honest and open with us. Thanks also to our donors who've made this possible, including Ultragenics and our Charlie's Angels Giving Circle. I'm going to post this webinar survey in our chat. Your response really helps us to measure the impact of our program and plan for the future. And we really appreciate your thoughts. And with that, thank you all, and be well. You can join us next on December 16th. We'll have Dr. Allison Boyce of the NIH on to talk about research in FDMAS. And we're really excited to check in about the community's progress and hear from her. So thank you all.
Thank you. Oh, Dr. Paul left. Thank you, Tova, for everything.
Thank you. This has been